Hi everyone, welcome to Conversations about Living and Dying. Free interactive webinars with experts on issues related to living and dying well. I'm Renee Jabir, your host for this webinar. Today's is entitled, What Happens to the Dying Body? As a Western society, we have lost the art of being able to recognize the normal signs and symptoms of a dying body. Consequently, we worry relentlessly about our loved ones suffering without understanding what they're actually going through. This webinar will discuss what happens within the body when it is dying, moving from the brain down to the gut and beyond. It will help explain some of the experiences people have shortly before they die. Dr. Amanda Landis is a community palliative care physician working in the Canterbury region for Nurse Maud Hospice Palliative Care Service, although today she will be speaking in her personal capacity. She also supports the West Coast Palliative Care team and is always looking for ways to collaborate with other neighbouring regions. Her current areas of interest are people with non-malignant palliative care needs, especially chronic obstructive airways disease. She is currently doing research into lymphedema, pancreatic cancer, and models of rural palliative care delivery. She is also a senior clinical lecturer at the University of Otago Medical School, currently developing a new palliative and end-of-life care module in Christchurch. Education is a major focus for her, and she has given presentations to a variety of audiences, including nurses, allied health, other medical practitioners, as well as the general public. Welcome, Dr. Landis. Over to you.
Very long presentation, so it won't take too much of your time. Thank you so much for linking in today. Probably three significant things have happened in the last 24 hours to do with this topic. The first one for me anyway is that we heard about Colin Meads dying from pancreatic cancer this morning. And it's really interesting how the media portrays that, because they talk about battling cancer and losing the fight, and really coming to the end of one's life is not hopefully a battle or a fight. It's actually inevitable and part of living and being part of the human race. There may be a few things that Lady Meads saw happening to her husband as he was dying that won't be reported in the media, but I'm going to go through a few things today that may have happened to Sir Colin Meads as he was entering his final phase of his life. The other thing that happened is I was watching a movie called Cinderella last night. I'm a bit of a romantic chick flick buff, and I noticed that the king, he died in the arms of his son, the prince, and he just shut his eyes and took his last breath. And this is really the way that death, again, is portrayed in movies, and it really isn't necessarily the way it actually happens, and has probably skewed our view quite a lot to what death looks like in the current modern world. The last thing that happened was a friend came round last night to watch the rugby, and he said that his auntie had died. She was 89 and was living in a residential care facility or a nursing home, and she literally shut her eyes for her afternoon nap and never opened them again. And I thought, well, actually, that's probably what most people would want, but it probably only happens about 20% of the time. So I want to talk a little bit about what actually happens for people, what they may be experiencing and what families see. And sometimes there's a bit of a difference between those two things. So palliative care, I think it's got a bit of a reputation out in the community. I was talking to someone, one of the dads at the soccer field yesterday, and we got talking about what I do, and he said, isn't it just for the last few days? And I said, no, it really isn't for the last few days. Sometimes I know people for years, and they come on and off my service as they require. But palliative care is not a specialty. It's not about me being a palliative care specialist. It's actually about everybody understanding what is happening for somebody and approaching them in a way that improves their quality of life. It's not just their quality of life, but it's also their family's quality of life as well, because of course families are majorly impacted by anyone, any loved one who is losing their health. Palliative care is for all ages from 0 to 100 and beyond. It's also for any illness. So again, people think that palliative care is really there to support people with cancer, and we do, but we also help look after people with all sorts of different illnesses that are life-threatening. And how we do that is we do our very best to prevent and relieve suffering, and suffering is a very subjective thing. And so we do a lot of listening and trying to understand what is impacting on people's quality of life. And we treat things like pain and other problems. We look at psychosocial issues. We have young people sometimes on the service that have young children and aren't sure who's going to care for them after they have died. We have all sorts of social and emotional issues that we try and help people with as they approach the end of their lives. So we're going to talk a little bit about what we call the physiology of dying. And I just like this quote, that life is a great sunrise, and I do not see why death should not be an even greater one. Now, I'm not trying to say that all deaths are beautiful and significant and meaningful for everybody, but they can be. And just as I've seen beautiful births, I've actually seen beautiful deaths too. I remember watching a woman in her probably 60s next to her husband, and as he was taking his final breaths, and she was reading poetry from his favourite book. And it was hugely beautiful and sacred and wonderful. She understood what was happening, and they'd had good communication between the two of them all along. So I definitely have seen what I would call beautiful deaths. What is death? Well, it's a physical end, obviously, but I talk about the fact that when someone's given the diagnosis of a life-limiting illness, whether it be cancer or heart failure or kidney disease, then they have the amazing opportunity to be able to begin to transform. And I remember quite a significant thing for me was, I think it was last year or the year before, Martin Crowe died, who was one of our great cricketers. And his wife, Lorraine Downs, was speaking at his funeral. And she said something that really stayed with me. She said, from the minute he was given his diagnosis, he became a better man. He got down on the floor and he played with the kids in a way that he never had. We communicated in a way that we hadn't, and he actually improved as a person. And that's something that we actually see quite a lot in this job, that people's priorities change and they begin transforming as people and thinking about what's really important and putting their time and energy into that. For some people, death's actually a punishment, and probably the group that come to mind most for me are those that have smoking-related lung disease, who know that they perhaps have played a big part in causing the damage to their health and feel that it is their kind of lot. Quite often when they say that to me, I would say we all have vices and we all make choices and we all deserve to be cared for and supported, no matter what our choices might have been. It can be a reckoning, and actually for a small group of people it can be a relief, and that's not necessarily a bad thing. That's an honest human emotion, and we certainly let people know that there's no judgment involved with that when we come across that particular belief. So there are different stages of dying, and not all patients go through the stages. That's quite important to remember, The stages do vary between people, but it does help us to have a bit of a guideline as to what might be happening and the different time frames. You will have all heard stories about people who say the doctors only gave me 6 months 10 years ago, or they gave me 3 months a year ago. And I think the reason that doctors are so bad at giving prognoses and timeframes is because we don't really know the person. We don't know what they bring to the table, what kind of reserve they have, whether they have a strong spirit, or come to the table with the illness with a strong body. So it's really important that we get to know and hear from the person themselves and their families about what kind of person they are and have been, because that actually helps guide us as to what may happen down the track. The other issue about being in dying stages is that for families and friends, there's nothing really left to do. And quite often that's really hard in our society because we like to do things and fix things. But actually at this point, when somebody is in their final days, the best thing you can do is be. Just be around, be a support, be a presence, talk about old times, get out the photo albums, get familiar tastes and smells going in the house, those kinds of things. So there's very little to do, more about being around them. So there are a few things you may see as people enter into their last kind of month or weeks. They may become restless and they may become confused. And quite commonly, family members will say to me, they're not remembering quite so much, or they get us mixed up, or they aren't as sharp as they used to be. And that's actually very, very common. We take for granted how much energy it takes to be able to concentrate and focus all of our waking hours. But when we have an advanced illness, that becomes kind of beyond us. It takes too much of our time and energy. And so we can become kind of confused. Sometimes people withdraw from social interaction. And often I hear probably the more mature group of my patients saying that they find the grandchildren hard and they feel guilty about that. But having little children around them, or lots of noise, or lots of people coming and going, can get really tiring for people, especially if they feel the need to keep talking, keep interacting. If families come to a point where they realise their loved one is really just needing to rest, but does want to be around and part of the social interaction, then that's okay. People can come and go and not worry too much if people are sleeping or nodding off. But they often do find it hard to keep up social interaction to the same level as they did before their illness. They do become sleepy. I'm going to talk a little bit more about what apnea is. It's to do with breathing. And I'm also going to talk more about food and fluids, because that's a really big one. But sometimes people actually state that they know they're dying. Quite commonly I say things like, can you feel yourself slipping? Or can you feel yourself physically changing? It's actually happening to them. They know exactly what it feels like. And so it's important to listen to what cues they may be giving you. Occasionally we have people who see relatives who have long died. So men and women in their 80s seeing their parents is not uncommon, and certainly a sign that things are changing. And often people are sort of trying to tie up loose ends. So we're just going to look at the physical changes, basically from the top of the head down. And we're going to have a look at the brain, because as the brain becomes compromised, either due to lack of oxygen or blood, then you do see changes in things like consciousness, communication, swallow is a really important one, and sphincter control. So as people become less well and start entering their dying phase, they do become drowsy. Now, it's important to make sure it's nothing to do with what doctors or nurses may be doing, like medication, but generally, as long as the medication has been titrated carefully, the drowsiness is actually to do with the illness. The body cannot keep all those systems going 16 hours a day like they used to. They just need rest, and people lose concentration and get fatigued and may nod off even mid-sentence. That's pretty normal. I would say 80 to 90% of people would have fatigue or drowsiness in their final few days or weeks. They even have difficulty awakening at times, and then eventually, very commonly, people lapse into a coma and become unresponsive to voice or touch. And that can look very peaceful to families and friends. And so this is reasonably common for the majority of people. They do have trouble communicating, they have difficulty finding words, or they might start talking in short sentences simply because they don't have the energy for big, long conversations. Another thing that you might notice is people feel, people can hear your question, but there's a delay in the answer. So they actually take time processing the question, getting an answer, and then getting it out. Whereas that was once sharp and quick and happened without people thinking. When people are actually winding down and their brains winding down, there's a delayed response to questions. Just taking time, waiting for an answer, and trying not to be too alarmed by that, as it is a pretty natural thing to happen. Another thing that you may notice is that people turn to speak to someone who's not there, or may look beyond you, and then eventually become unresponsive. Now, swallow is really important. Swallow is actually something we take for granted and happens several times a day, but it takes a lot of brain power and muscle power coordinating for a swallow to happen effectively. And the issue is when you become extremely fatigued, that coordination starts to be lost. And that's really important for things like medication choices. So if your relative is having tablets, that becomes tricky as people get less well. And if they lose their swallow, we need to give them medication other ways than tablets. And we have ways of giving medication under the skin, not into veins because that's messy and causes bruises, but under the skin. And we can manage things like pain and nausea and restlessness and anxiety with medication under the skin. They may actually also start to cough or not be able to get tablets down. You can see that they're just kind of chewing and chewing, or the mouth's going round and round and they're not really quite sure what to do with it, what's in their mouth. They may actually lose their gag reflex, and then you start to hear secretions at the back of the throat, and that can make quite a noise that can be alarming for relatives. But to be honest with you, the patient themselves will be unaware of that sound and of that noise. So that's really important and something that families tell us is alarming, but we know from experience and from, I guess, a lot of talking amongst the palliative care community and a little bit of research as well, that is not distressing for patients. Now, things like sphincters, which usually keeps fluids and gas in, actually get a bit lax. And then you get things like incontinence of urine and of feces. And this is really difficult for families. So if you're looking after a loved one at home in the last few days or weeks, toileting is probably the number one issue for families to manage. And if you've got an elderly person being looked after by an elderly spouse, that can really be the tipping point. You really do need more family members able to stay or support often in the last few days or even weeks, which can get tricky for some families. If it's not cleaned or cleared away quickly enough, it can actually cause skin problems, and then you can start to get things like fungal infections. So most services across the country will have community nurses that come in and help, but families do need to be aware of kind of skin issues for people at the end of life. And then we do see what we call terminal delirium. So delirium is when people become very confused. Quite commonly, they're up at night and awake during the and asleep during the day. It's what we call day-night reversal. And again, you can see how this can be tricky for families, particularly those still trying to work. So we do what we can to try and help reverse that. But it is something that shows the brain is starting to wind down. People can become agitated and restless and need to move, and we tend to use muscle relaxant medication for that to try and help them relax and not feel as anxious in their body. So an anti-anxiety and a muscle relaxant are the types of medication that we use. Now, the thing about moaning or groaning is, of course, we have to make sure that that's not pain, but it's not always pain. So quite often I go into a home and the families are like, Bob or Jack or Jill is in pain, and I look and I can see the body's very relaxed and the face is very relaxed, but they're making noises, and the family is taking that to mean that they're in pain. And that's very distressing, and people feel like their loved one's suffering. But actually, sometimes people are actually making noises. They're still trying to communicate. They may be dreaming. They may be seeing people and things that we don't know they can see. So it's quite important to not put every noise that someone's making down to pain unless it's clear that that's what it is. And I think that's a really important point, because what ends up happening is we give medication to somebody because the family's worried they're in pain, when we feel quite comfortable or confident that their body language is not showing that they are in pain. So it's important to try and work through that and just check in with health professionals or even other family members about what you think's happening. So the sorts of things I say to families, I have these family coaching slides, is I really, really implore you, if you do have family members who are close to dying, to open the lines of communication before the opportunity's gone. The problem is when people start to be less communicative, sleep more, find it hard to hold a conversation, you've lost your opportunity, and that's a real shame. And what we find is quite often a husband's trying to protect a wife and a wife's trying to protect a husband, and neither one of them are talking. One of them walks us down to the letterbox to talk to us outside of the house, and we realise that they actually both know what's going on, but they're not talking about it together, and that's a real shame. So I do encourage you to open the lines of communication before the opportunity's gone. The other thing is, as the brain is winding down, as the rest of the body, the messages aren't getting through, and that's why sometimes people make sense and sometimes they don't. So it's a little bit like crossed wiring in a house. Sometimes the wiring probably goes in the right direction, other times it doesn't. The other thing that's important is to let the person know that you realise what's changing them or making it hard for them to communicate with you is actually the disease's fault, not the patient's fault. So there's no blame involved. It's actually the underlying problem that's causing issues. And I guess another important thing is, if people are coughing after eating or drinking and looking like it's kind of going down the wrong hole, then it's probably time to stop doing that. And we're going to talk a little bit about food and fluids at the end. So what's happened moving down into the lungs? As someone's body's winding down, the lungs stop being able to put oxygen into the body. And what you'll notice is people's skin changes colour. It becomes pale. It may actually become mottled or sort of different colours in a particular region. And people's hands and feet become cool. And again, that's something that is just part of what happens. It's the lungs not getting the oxygen around the body. And people's breathing changes. So what commonly happens is people actually have apneas, and apneas are where your family member actually stops breathing and then restarts very quickly, and then stops breathing and restarts very quickly. And this can look really alarming, but the person will actually not be aware of it. It is not painful, and they are unlikely to be aware of what's happening. What we find is family members sitting by the bed with a stopwatch and actually counting the apneas and the seconds. And when you come in, they say, oh, that one was 32 seconds or that one was 10 seconds. Now, that's probably not quite the focus that we would want. We want you to be actually be with that person, not worrying about the numbers, holding their hand, wiping their brow, making sure they're comfortable in the bed, being with your family and your friends, because this is a time that you're never going to have again, and quite commonly families are coming together who haven't been together for months or even years. So it is just an abnormal breathing pattern that happens when the lungs are starting to wind down. And I mentioned about the loss of gag reflex and the pooling of the secretions at the back of the throat. Some of you might have heard of this term, the death rattle, which is, I know, a horrible term, but it does actually describe what's happening. It's a noise going over the secretions at the back of the throat. With the gag reflex gone, that means the brain's really pretty much wound down completely, and the person will not be aware of that sound. It doesn't happen with everybody, but it does happen quite commonly. So what do I say to families? Breathing may change and become irregular, but that this is not painful. Now, the important thing is that oxygen is not helpful at this stage. Blowing oxygen into someone's nose, into lungs that are effectively dying, is not going to be helpful. And actually, you're putting plastic on someone's face, and they're likely to kind of swipe at it because they can't understand what's on their face. A chest infection is often the mode of death. So there's a very old saying, pneumonia's the old friend, something like that. Sorry. And again, people are unlikely to be aware of the fact that they're developing a chest infection, and antibiotics are not helpful. So pumping antibiotics into someone's vein when the lungs are winding down and the immune system's winding down, which is how antibiotics work in the body, is actually pretty much pointless or futile. So giving antibiotics to someone at the end of their life is not something that we would want to see. Sometimes when we're not sure somebody's dying, we may give them a trial of antibiotics, but that may only be for 2 or 3 days to see if it helps. If it doesn't, they should be stopped. I think that's quite an important point to remember. The noisy breathing I've mentioned, but patients are unaware, and we do not suction. So this is something that's really important. The noise is the mucus or secretions right down deep at the back of the throat. So putting a tube down and trying to suck them out will not help, and will actually potentially cause some damage at the back of the throat. So it's not something that we tend to do. Okay, so we're down to the heart, and there's a large load on the heart when the lungs fail, and the pump fails of the heart as well. And this affects the lungs backwards and the liver forwards. So the heart's obviously a very important organ in the body, and as it starts to fail, we see some things. What we see is a fast heart rate. So if you put your hand on somebody's pulse at the wrist, you'll feel quite a fast heart rate. Patient will not be aware of that and will not feel any undue effects from that. Again, you feel the cool hands and feet, and things like you'll notice someone's urine going quite dark, and then there'll be less urine made by the body. That is just part of what nature does as these organs are winding down. So as the pump dies, the patient may have a drenching sweat. That doesn't happen for everybody. Again, they won't be aware of that. The pulse is weak and irregular. If the patient's even in a sort of comatose state, if you feel the pulse and it's very strong, then they're likely to have a bit of time left, maybe even several days. If the pulse is very thready or absent, they really are pretty close to dying. So what do I say to families? The heart or the pump, if I've got an engineer or a plumber in front of me, I talk about it in terms that they may understand. The hands and feet may be cool to touch. They may change temperature. Now, it's very important. IV fluid is not helpful at this point in somebody's life. So as the kidneys and the heart and the lungs are trying to wind down, giving somebody IV fluid actually puts pressure on the system that it can't deal with. What ends up happening is the fluid just leaks out into the legs, into the tissues of the legs, which is what edema is, or even into the lungs, causing more secretions. So we really do not encourage medical teams to start IV fluids on people that we think are dying. That is not the right treatment. And numbers are no longer important. So as the brain, lungs and heart fail, other body systems fail as well. And one of the systems that really struggles, which is not surprising, is the gut. So as the brain and the heart and the lungs are just managing to keep their systems ticking over, the gut is as well. And what happens is the metabolic rate decreases, almost stopping. So it goes right down, and people can actually exist on very, very little food and fluid. In the days or weeks leading up to the death, people do not feel like eating. They just don't. The gut is just ticking over. Big meals, people just don't want it. And this can cause quite a lot of conflict with carers, because carers are trying to feed people up to keep them alive. And they would put food and life and food and hope together. And that, when somebody is at the end of their life, is just not the case. What happens is, if people force themselves to eat to keep the peace with loved ones, they end up getting bloated and feeling nauseated, and actually feel worse than if they're allowed to just eat the little bits that they feel they can and drink the bits that they feel they can. And what I talk about with families is getting into a bit of a rhythm of letting the person tell you when they feel like they can have something, and not worrying too much if it's only a mouthful or two. That's okay. They're actually going to tick away on very little food and fluid. They will lose weight, but that's not necessarily lack of food. And we know that because the research shows us that if we put artificial food directly into someone's bloodstream and pump food into them, they actually still die, and they actually still lose weight. And there's actually side effects from doing that. There's harm associated with doing that. So it's quite important to just let people eat and drink as they feel they can. And if they don't feel hungry or thirsty, there's no symptom to worry about. They will actually tell you what they can manage. The weight loss is part of the illness and part of what nature does when people have advanced illness. So what do I tell families? And we're almost at the end here. That the body can no longer process food. The gut doesn't know what to do with a big meal. It's too much. That actually the brain, there's a release of a particular hormone that leads to euphoria in the brain. And therefore, nature has kind of set it up, if you like, that it takes away hunger and thirst and allows the body to wind down in a natural way. Fatigue and weakness are normal. They are not related to a lack of food or a lack of fluid. In most people, obviously this is not 100%. They do need to be assessed. But for many, many people, the fatigue is the illness, not a lack of food. And I have had families that have really been hyper-vigilant about getting food and fluids into people. And I've seen the harm that it can cause. And intravenous feeding is also not helpful. Now, the other thing, and I've even heard my colleagues say this about no longer drinking, that they must be dehydrated and that must be painful. Now, when somebody's kidneys are winding down and they're no longer thirsty, that's not dehydration. That's not like you and I being caught out on the ocean with no water. and dying of dehydration. These people are at the end of their lives. It's a completely different state. So they don't even look dehydrated. We've had patients that have had no food or fluids for several weeks before they die. They are not starving and they are not dehydrated. It is just the body's natural way of winding down. I think that's really important and something that the general public probably needs to hear a little bit more. So I just wanted to show you the two roads to death, and just to reassure you that the one on the left, the usual road, is the usual road. Most people die naturally, die well. It sounds to me that Sir Colin Meads had a peaceful death, they said, in Consequently Hospital, and that is actually the norm. The difficult road is why people like myself exist and teams that I work in, but they're difficult for a whole host of reasons. Not necessarily because they're painful, not necessarily because the medical profession has let people down or whatever. It's actually that people bring to their illness all sorts of emotions and background and ways of engaging with health professionals, and the list goes on and on and on and on. And so what we do is try to smooth out the difficult road as much as possible. And I think everyone around that person has a responsibility to at least try and understand what's happening, and really work on what the person's goals are going forward. So finally, signs of impending death. By the time they've got that funny death rattle at the back of their throat, they really are in their last day. If they've changed colour and are very grey and mottled in the face or hands or legs, then they're really in their final hours, as well as if you can't feel their pulse anymore. So the person dies, and hopefully they haven't left things until the last minute. The really important thing after someone dies are the rituals of your family and of that person. So that's where something like an advanced care plan, where you write down what you actually want, can be very important. I saw one recently where the person had written that they wanted certain music played. It can be very specific, or it can be not so specific. All sorts of rituals. These are not necessarily religious rituals. They are just things that feel right for a family. It may be a glass of wine, whatever it may be. There's also a sacred silence. It's a very sacred place to be with a family after somebody has died. It's important to help that family get through the next steps, and hopefully there's been some discussion before the death as to what that person may want. And it's also important to look after yourself. And that is the end.
Would you like to type in some questions in the column on the right, and we'll present those to Dr. Landis to answer. I've got a first one for you.
Yes.
If a family feels like they're not really, that their loved one isn't really getting the care that they think they need,
yes,
what would you suggest?
I think possibly it would be quite good to make an appointment with that person's GP and ask if there is a specialist palliative care team around or available, or if they're under a specialist, say an oncologist or a cardiologist or some other ologist, ask if they can have a referral to their local hospice or specialist palliative care service.
Dr. Landis, how can you tell if a person is in pain?
Well, often they'll be able to tell you. Pain's a really interesting symptom, because when you ask people to rank their symptoms of distress, pain generally does not feature in the top 3 for most people. It's a very subjective experience, and lots of things help pain and worsen pain that have nothing to do with medication and that have nothing to do with physical issues. So having a fight with your sun can heighten someone's pain, even though there's been no more physical damage, or uncertainty, or fear, or worry about finances. So that's why when we talk to someone about pain, we actually try to find out what else is going on for them, because quite often helping them to fix one aspect of their life, strangely enough, actually helps their pain as well. And I've seen this time and time again. Pain is just layer upon layer upon layer. It's not just physical. When somebody's not able to tell you or talk anymore, how you can tell is how relaxed their body looks. If they're in bed most of the time and they look quite relaxed and they're not tense and they're not grabbing themselves in a particular area or grimacing. Grimacing is another good one. So you can tell by their facial expressions and how relaxed their body is. And we talk to family members quite a lot because they know that person's face so much better than we do as to whether they think they might be in pain or not. But it's sort of a conversation.
Okay.
Does that answer your question?
Yes, thank you. Okay, Anne asks, Mum wants to stay at home, too many steep stairs. Where does one get help from?
Is she at home by herself? Or are you with her at home?
Okay. Don't know if Anne can answer right now. I guess, say she is by herself. What would you suggest?
It's actually almost impossible for someone to die at home on their own. They actually will require a family member moving in, or paying carers is extremely expensive. I had a family recently whose son, who lived overseas, was paying for carers, and it was $12,000 a month. So very few families can kind of afford that. But if you can keep people as long as possible at home and then open up the conversation about where else do you think it would be acceptable for you to be cared for before it's a crisis. It's when people, are at home struggling, they fall, they fracture something, or they push the panic button, get into hospital, and then have to go into residential care or nursing homes without ever going back to home. I think that's incredibly sad. I think it's better to try and have a conversation about where else would you find it acceptable, and at least having a bit of a backup plan. But I think it's incredibly hard for the elderly to be at home and almost impossible to die at home without someone else living in.
Okay, and you would suggest that a person asks their doctor about community palliative care in the area, is that right?
Yes, so I cover quite a lot of Canterbury, but I also cover the West Coast. Obviously, I'm not there in person all the time, but there are local teams on the ground, and then quite commonly there's a specialist service helping support the local teams. So we do have reasonable coverage across the country. It just will look different depending on where you live.
Okay. Dr. Landis, I've heard many people say doctors already hastens people's death. What would you say to that?
I find that such an interesting thing. I think it's this putting up medication and then seeing your loved one be less and less well and more fatigued and then go into a coma and thinking that that's the medication that's done it. And it's almost certainly not. When someone's been on something like morphine for more than 2 weeks, it's incredibly hard to use morphine or opioids to render people unconscious. It's actually incredibly hard. So what you're saying, the doctors are putting up medication, and what they should be doing is in response to symptoms or things that they're seeing which mean that people aren't comfortable. And then you actually adjust or titrate the medications in response to that. And there's always a last medication given or a last increase in the medication. That does not mean that the death has been caused by that. The death was happening anyway, and the medication is titrated to keep that person comfortable. So I think there's been this kind of myth or strong perception by families who perhaps don't quite understand what's happening, that the medication going up is causing the death. And that's just not the case. Quite often, I'm actually lowering the medication. If I think someone's over-medicated, I will lower it. So it should be in line with what the person needs to be comfortable. And so that's a conversation you need to have with your relatives' medical team. And I've been working in this region for 7 years. It is so incredibly rare to see doctors giving medication that's not appropriate. Incredibly rare. So I really think that's a perception of family who potentially aren't understanding what's happening.
Thank you. Here's another question. Do you recommend mouth cares, swabs, and using the likes of saliva substitute for dry mouth right into the end stages for dry mouth, or are patients not bothered by this?
Oh no, definitely. Mouth care is absolutely high on my list. So mouth care, keeping people's mouths moist and clean and using swabs is really, really important, I think, because we know that quite a lot of the medications we do use cause dry mouth. So they're very effective for things like pain management or keeping people comfortable, but they do have side effects of dry mouth. So definitely, I think mouth care is probably one of the number one things families can do to help keep people comfortable. Things like Vaseline on the lips, cleaning people's teeth with a little bit of bicarb soda and a little bit of tepid water, keeping the mouth fresh, definitely. Yeah.
Here's another question. Can all pain theoretically be managed?
Yes, this comes back to what I was saying before. Pain is layers upon layers upon layers. So I could probably make everyone pain-free, but for some people, the medication we'd need to use for that to happen, you'd actually lose that person a bit. So we walk this line between keeping people comfortable and functional and the pain managed and the side effects of the medication. But just like I was saying before, pain is not all physical by any means. And you'd only have to be in the job I'm in for a week where you would start to see that. So we need to look at pain as something other than just what's going on in the body. We need to find out how they're going with their friends and their family and their workplace and, the fear they may be feeling and the uncertainty. And pain is just so complex for many people. And I think we need to move away from this kind of sense that it's one-dimensional when it isn't.
What would you recommend to families who think that their loved one is in emotional pain that's not physical?
Yes, yeah. I think what I was saying about opening up the lines of communication, it's okay. Tell me what's at the root of this for you. Are you frightened? I ask patients that quite a lot. Are you frightened? What in particular are you worried about? And if it's a relative, you may know that they had a traumatic event in their past life, in their past, or that they watched their mother or father go through a bad death 25 years ago, and they're really fearful that's going to happen for them. Try and dig down to finding out, or at least opening up the lines of communication about what might be driving that emotional pain. It may be that they're really sad they're leaving you, and that's okay. That's normal to feel sad. Or they may feel it's really unfair or be frustrated or angry. They may be young. We have patients in their 30s and 40s who feel cheated, and I think that that's perfectly reasonable to feel that way. Sometimes it's just naming the emotion. I can see that you're angry. I can see that you're frustrated. Can you talk to me about that? So I think the more we open up the lines of communication, the more likely we are to get to the heart of what's driving that emotional pain.
All right, so making the person feel heard is a big step, isn't it?
Definitely. And, we're in this busy world with lots of distractions, and I think sitting down and what I would call actively listening is a really important skill to foster when you've got somebody who's at the end of their life.
Mm-hmm. Okay, we've got two more here. One person says bowels in final days, i.e. when to stop bowel intervention, loaded bowel and anxiety.
Yeah, I think the bowel does slow down, but if you've got a kind of bottom full of feces, then it's probably best to have a little suppository and clear it so that it doesn't feel uncomfortable. I would be hoping you had community nursing that would help you with that side of things. Even in very rural areas, there's rural nurse specialists and the rural practices. So it can make people quite uncomfortable and restless if they've got a bottom full of feces, and so it is important to check. Obviously, when people lose their swallow, they can't take laxatives anymore, so that's a natural end to the laxatives. So that's when we start just making sure the bottom end is clear and not causing problems.
Okay. One person asks, I understand that palliative care can be matched to the genome. Is that true?
Palliative care can be matched to the genome.
Yeah, I haven't heard of that before.
Oh, that would be new for me. If someone out there knows anything about that, send it on to me. I have not heard that before. Do you mean, I wonder if it means people who do the job or whether it means people who are at the end of their lives. I'm not so sure. I do think most of us that work in palliative care have similar personalities, perhaps, but I don't know if that can be matched to the genome.
Okay. Right. So it's 4:00. Thank you very much, everyone, for joining us. We have two more webinars coming up. On Sunday the 3rd, it's with Vicky Walsh. She has terminal brain cancer, the same cancer that Lucretia Seals and Brittany Maynard had. And then on the 10th of September, Dr. Landers is with us again, talking about 10 myths about palliative care in New Zealand. Dr. Landers, would you like to just say a brief few words about that?
Yes, I've tried to take some of the public perceptions or things that I've seen in the media or talked about with friends and family that people think is part of palliative care or that we do or don't do, and I'm going to talk through each of them in a bit of detail, and then I'm going to leave number 10 for the audience to perhaps put forward. So I've got 9 myths, and I'm hoping number 10 might be coming from the audience.
Okay. Right. I see that there's one last question. With regard to those pro-euthanasia, is it more about the patient's condition or the pain that the family is going through?
Honestly, I think it's mainly about fear. Fear on a whole raft of levels. Fear of the body changing, fear of the unknown and what that person may go through, fear of being a burden on the family, fear of being a burden on society. So whenever I think about what's driving it, I think a lot of it is fear. And then on top of that is this need to have autonomy or choice, which I think, the ethical principles, there's more than just one ethical principle, but autonomy has become this massive beast that seems to be driving so much of society, and choice is not necessarily the best thing. Obviously, it's an important concept, but it just needs to be thought about a little bit more because it's very complex. So I think a lot of what's driving the pro-euthanasia debate is fear, and then this kind of insatiable appetite for control and choice.
What is your experience? How many dying people actually want euthanasia?
Very few. In fact, most want to live. Those that talk about it earlier on when we first meet them, we see it as a huge cue for us to be digging deep and trying to find out what's driving that request. And honestly, I would say 95% change their minds. We've had various cases go to the media and want to talk about their wish for euthanasia. And then I've heard, I guess, from colleagues that those same people, when they are days from dying, do not want to even entertain the thought of euthanasia. So it's incredibly rare that somebody maintains that wish, because generally it highlights to us that we need to work harder. And that's what I think we need to not lose, that drive to work harder and dig down and find out what's at the heart of that request. And that's what I'm worried about we will lose if the law changes.
Yeah. Okay, well, thank you very much, Dr. Landers. We really appreciate your time. And to everyone, Dr. Landers has given her time for free. If you appreciate her presentation, could you please make a donation and we'll pass that on to her. It'll be in the email that we send you with the link to the replay as well. So thank you very much once again for joining us. Spread the word. Please direct people to the website. I'll just put that up. And it is livinganddying.org.nz. We have more webinars coming up. We're very interested in people's suggestions for future topics as well. So yeah, please do register for future ones as well. And thanks again, everyone.
Thank you.
Bye.
Bye.